Welcome to Session 7, Reimagining Health, the Framework for Active Collaboration. We have Dr. Daniel Sands, who is the co-founder of Society of Participatory Medicine, who will be giving the presentation today. Dr. Sands?
Yes, thank you. It's a pleasure to be here with all of you. I think this is going to be fun, hopefully, and interactive, and will be a nice complement to the presentation that we just heard. So let's kick it off so I can leave some time for questions. First slide. So I've entitled this Reimagining Health, a Framework for Active Collaboration. And just to, so you know my background, I'm a primary care doctor, but I have training and 30 years of experience in clinical informatics. Although I went into informatics really because I wanted to empower clinicians who are taking care of patients at the point of care, what happened to me is that in my own practice, I realized as I was developing these tools that technology could be just as empowering to patients and caregivers as well. And that really changed the trajectory of my career. So next slide, please. So healthcare is in a crisis. Next. You can just run all the animations on this one. We have an epidemic of chronic disease, an aging population. We have rising expectations among patients as customers. Complexity of healthcare is enormous. Despite that, we have poor information exchange and coordination of care, rising costs, lack of trust, poor satisfaction. It's a mess. And I know that all of you as health advocates are experiencing this with your clients. Next slide. And despite this, we think about healthcare, and we is not just patients, but it's doctors too. We kind of think about healthcare as if it were a car wash. This is implicit, not explicit. What I mean by that is that the healthcare system is the car wash. The patient is the car, and the patient is unhealthy. The car is dirty, and the patient enters the healthcare system, car wash, somehow gets health sprinkled on them, and magically comes out the other side healthy. Well, that's not working. There's a lot that's not working with that. You know, there's no, this is what's causing us to have a healthcare system that is not really personalized. It's expensive. It's inefficient. There's so much wrong with that model of healthcare. This is the model of healthcare that when a patient is sick, they go to their doctor and say, "I'm sick, doctor, fix me." Well, as a primary care doctor of 30 years, I can tell you that that approach just doesn't work unless a patient is unconscious. In most situations, patients need to think differently about healthcare. Next slide. So what is the cure for this? Next slide. We need to think differently. What should patient care really be? Next. It should be a collaboration on the patient's health. That is a collaboration between the healthcare professional and the patient, where the topic of that collaboration is the patient's health. And collaboration, next. Collaboration applied to healthcare is participatory medicine. Next. Think about collaboration applied to any aspect of your life. If I were live with you, I would ask you, how many of you have collaborated in any aspect of your life? And of course, we always collaborate. We collaborate with clients. We collaborate with our partners. We collaborate with business people. We do research collaborations, and on and on and on. If you think about those, think about what are the elements of a successful collaboration. And I would say that 5 elements that are really important are: next, open communication; next, shared decision-making; next, mutual respect and trust; next, information sharing; next, engagement. These 5 elements are critical for any sort of collaboration. And I would say if we apply these to our collaboration between patients and healthcare professionals, that's important. And that is participatory medicine. So next slide. The online population is rising, and this data only goes through 2015. And what I want you to notice is that in every single age group, and this is no surprise and matches with your experience, use of the internet has just taken off. And among the youngest in our population, in the graph that you're looking at, this is people who are age 18 to 29. Almost everybody's online. No surprise there. But what's really important, and this touches on something that the prior presenters presented, is that it's not just about age. You can't assume that just because someone's over 65 that they're not online. And so the bottom bar here are people 65 and older. And back in 2015, which is now 5-6 years ago, right? 58%, over half of these people were online. And by the way, at that time, the fastest growing users of Facebook were people over the age of 65. Next. So this is where patients live. Okay, all of us, all of you, and our patients, we're living in this world of technology. We're living in a world of frictionless interactions. We're living in the world of Apple and Google and Amazon, Airbnb, Uber, all these things. These have irrevocably changed society and changed our lives. And it's made it easier to do many things. As you participate in this conference, some of you may have ordered something on Amazon, and it'll probably be here tomorrow. And it's remarkable, right, how this has happened. Next slide. So I will ask you to think about these things. We can respond to them in the chat later. But I would ask you to think about these things. First of all, what are your expectations about the medical care that you or your family receive? And then the second question is, what do you need to be an active participant in your care? Next slide. Let's talk about the online health habits of US adults. 80%, next, you can just fill the slide. 80% of online adults have looked for health information. Actually, a survey just came out since I put together these slides showing that it's actually higher than this, and it's closer to 90%. Every day, more people search for health information than see a physician. And what should be quite humbling to those of us who are healthcare professionals is that more than half of the people who go online act on that information. A third have read about others' health experiences online, and this is very common among teens and young adults. A quarter of us have tracked our health information online. Unless you think, oh, I wouldn't do that, or I never do that, you probably do. If you have a wireless scale, it's uploading information to the cloud. Wireless blood pressure cuff, same thing. There are lots of different ways that we track our information online. And even using Apple Health or Google Health, you see what's happening is that you're putting information online. And even a third of online people use social media for health. Next slide. So one of the things that I often talk about is e-patients. What is an e-patient? Well, the E doesn't stand for electronic, despite the fact that I've been talking about the electronic and online world. E-patients, as been defined that was defined by Tom Ferguson back in the latter half of the 90s. Tom was a friend and a mentor, and he thought it was remarkable to see what is happening with access to information. And he realized that access to information made it easier to be what he called an e-patient. And you can fill this slide as well. E-patients are engaged, equipped, empowered, educated, and enlightened. That's what an e-patient is. The electronic, okay, fine, but that's not one of the E's. And the reason is that you can do all these things without being online. Being online just makes it easier. Next slide. So what do engaged patients want? You can fill this slide as well. They want information, they want convenience, and they want communication so that they can be involved in their care. After all, it's the patient's life that we're talking about. That's whose life it is. And that's who we need to make it easy for them to be involved. Next slide. I'm going to talk about each of these three things independently, briefly. So the first is, let's talk about information. Next. I would suggest, you can fill the slide, there are three types of information that are complementary to one another. Type 1 information, I feel, is general information. This is information about my disease. If I have diabetes, this is, tell me about diabetes. What is insulin? How does it work? What are the complications of diabetes? And so on. Type 2 information is information that's specific to me. It's specific to me because it's my health information. It's access to my record. I want to know what's going on with my diabetes. What's my hemoglobin A1C? What are the complications I'm having? And so on. So that's type 2 information. Type 3 information is peer information and support. It's the experience and knowledge of others like me. Other people who have diabetes or who have the cancer I have. What is it? We can learn a lot from these people. Next. So I want everybody to, every patient to get engaged and focus on all those types of information. On that type 3 information, Pierre Levy, who is not in healthcare, he's a philosopher and cultural theorist and media scholar at the University of Ottawa. He wrote, "No one knows everything. Everyone knows something. All knowledge resides in networks." And he didn't mean computer networks. He meant networks of people. Next. So I would say that in healthcare, we have a shifting paradigm. The first paradigm is information asymmetry. Information asymmetry is the traditional paradigm of healthcare, where the physician is the font of knowledge. The physician is the oracle. And physicians are often comfortable with this model. They say, okay, well, I know everything. My patient knows nothing. That's information asymmetry. By the way, that term information asymmetry, I didn't make it up. That comes from warfare and economics. It's where one person knows everything, the other person doesn't have access to information. And although physicians often feel comfortable with this model and being the omniscient physician, I would suggest that it's a burden. Why? Because if you actually talk to physicians and you ask them to be perfectly honest if they know, do they know everything there is to know about their specialty? They'll laugh and giggle. No, they don't. They can't know everything. So physicians are living a lie if they're acting like they know everything, because they don't. So we need to move to a model of information symmetry, where the physician and the patient are partners. And rather than feeling threatened by this, actually physicians no longer have to feel the burden of living a double life. They can be perfectly honest that they don't know everything and they're fallible. They can admit they don't know. That's really powerful and very hard for physicians. And if they do that, if we do that, we can go back to being healers in healthcare, because this is really why doctors went into medicine. It wasn't so they could be the smartest person in the room. That's just how it evolved. It's so they could be a healer. They could be healers. Next. So there's another dynamic at play that I know you've experienced as health advocates, which is power asymmetry in healthcare. The term power asymmetry really comes from the quality movement, because you have this situation where you have, say, an operating room team, and somebody observes that there's something wrong, and they're afraid to raise their hand and say, doctor, I think you made a mistake here, or you're about to amputate the wrong limb, whatever that is. And that goes back to, there's all kinds of cultural issues at play there. And we've got to recognize that power asymmetry exists in the office as well. There's that doctor with the white coat or the stethoscope or whatever it is, that you're coming to see the doctor. And that just sets up this power asymmetry. So we need to move from that being hierarchical to being collaborative. Next slide. So I recommend to doctors, and what I teach doctors is we need to ask our patients. We need to assess where our patients are in their lives, and are they going online to sort of seek out health information. We need to ask them every year when we do an annual visit or when we first see them. Because by asking them, we're learning, are they going online? But we're also giving them tacit approval. We're letting them know it's okay if you go online. You don't have to hide it from me. You don't have to be embarrassed. Patients are embarrassed about this all the time. Next. And that leads to honest disclosures in the future, because we get into problems when patients who go online may be altering their behavior because of something they read online, but they didn't share with their physician. And that's a problem. We want these honest disclosures next, so that we can have a trusting relationship. We don't want secrets. Remember, we talked about open disclosure. Next slide. So as part of this, as patients and advocates, we need to demand transparency. In order for you and your patients to be engaged in their health, we need transparency. We need transparency of data. Next. We need transparency of what things are going to cost. Next. We need transparency about what the quality is we're giving. And it shouldn't be just quality defined as I define it, but as my patients define it. And that leads to satisfaction as well. How satisfied were patients coming to see me? Obviously, your mileage may vary on satisfaction, but why is it that it's much easier to find out what people are thinking about that TV I want to buy than about my doctor? Next. So the next of those three things, we talked about information. Now we're going to talk about communication. Next. So I'm going to pick one example first, which is I'm going to talk about something that I've been involved with for a very long time. So think way back into the 90s. In the early 90s, when I was starting to practice, I started doing something really weird. And it was weird to my colleagues, and it was even weird to many of my patients, which is that I invited patients to do email with me. And I actually developed best practices for how to do that, which actually were published, the first of their kind, in 1998, which is an eternity ago. How do we use this in practice? What should patients be doing? What should doctors be doing? And so on. So, and by the way, when I say doctors, I mean healthcare professionals. It's just shorthand. I can say doctors, nurses, and other therapists. You get healthcare professionals. You get the idea. So first of all, let me give you some highlights. First of all, email is asynchronous, or e-messaging. It enables efficient and thoughtful communication. Because it's asynchronous, we don't have time pressure. One of the reasons health advocacy is important is that it's hard for patients in the confines of a very time-limited visit or a phone call to really articulate what's on their mind, to share their concerns, their problems, ask their questions. Email is asynchronous, and that allows patients to take their time in formulating their questions. I can tell you stories of patients who are elderly and tongue-tied in the office, or even immigrants who don't speak English well, and they can express themselves through email. But it's also good from my perspective, because I don't have to squeeze this into a visit. I don't have to make up an answer to a question you ask, or just pretend I didn't hear you, or walk out of the room. I can take my time. I can actually look up the answer. It's cost effective because it's not really taking a lot of time. Handling a phone call takes much longer than handling an email. There is a little bit of literature in that area, and it's just true. Because if an email is going to take up too much time, just ask the patient to set up a phone call or a visit or a telemedicine visit. Next. Because of these things, it's beneficial to both patients and physicians. It's not just about the patients. It's not just about the physicians. It really benefits them both. Next. And it really helps build a relationship and trust. If a patient is only seeing me once a year, or even twice a year, sometimes it's less often than once a year, it takes a while to develop that relationship. But if we can start the relationship that way and keep it going electronically through frequent light touches, that's going to sustain the relationship. And if you think about it, that's the same thing you do in your real world relationships. You might have a meeting with someone in real life and then not see them for a while, but you keep in touch with them on Facebook, or you message them, you text them, or you email them. The last point I'll make on this is that it is a channel. Email is actually a channel for healthcare delivery, because I can take care of many things through email. Not everything, but there are a lot of things I can, particularly if it's a recurrent thing, it's not complicated. It's not for everything, and we need to understand what the limitations are, but it's fantastic. And it can actually allow you to decide whether or not you need to come in for a visit, which also is an important thing. Next. So one of the things that is important in communication is this idea of shared decision making. This is a mnemonic that was developed by the Agency for Health Research and Quality. Health Research and Quality is which is part of the NIH, and it's called SHARE. And so I've called this climbing the stairs to shared decision making. And this is what we should be doing in our decision making. We should not be saying, okay, Sue, we've determined that you have this problem. You're going to take this drug. See you in 6 months. No, that's not acceptable. We need to first start with seek, welcome my patient's participation. We need to help my patient, help you explore and compare treatment options. We need to assess your values and preferences. We need to reach a decision together, and then we need to evaluate how it worked out. That's the SHARE approach. Next. Oh, sorry, we can flip through this. My bad. All right, so patient collaboration in care plan development, the shared decision making, leads to better adherence, more satisfaction, and improved outcomes. Next. And that is because there is co-ownership of the plan. If I'm just telling you to do something, you're less likely to do it than if we work and develop that plan together. Okay, the last of those three areas I want to talk about is convenience. Next. So how many of you, next, want to take some money out of the bank and you go to your bank branch and you stand in line to withdraw money? How many of you go to your travel agent, when we were traveling, of course, to make routine airline reservations? We don't do these things anymore, right? This stuff has gone by the wayside for the reasons I talked to you earlier about. We talked about what's happening to the world. It's just totally changing because of all these technologies. Next. So why is healthcare so backwards? Why is this typically what happens when you go to try to make a doctor's appointment? Next. So we make it difficult in healthcare. So this is a survey that was done about 8-9 years ago. And they asked people who had been to the doctor, so they're not totally young, naive people. Next. You can just fill this slide, I guess. So we asked them about whether they want to make online appointments, whether they want to do online billing payments, see their costs online, do email with their doctors, view their record online. And over 50% in all these areas wanted to do this with their doctor. Next. So then they asked, how many of you can do it with your doctor? And this is what they found, really a small proportion. Next. So rather than feeling depressed about this, I feel this is a huge opportunity for us. We have nowhere to go but up. Next. So I think a platform for a lot of the things that we've been talking about is something called a patient portal. And next. I suspect most of you know patient portals already. It's a great way to do various things. Next. This is a patient portal I helped develop. It was one of the nation's first patient portals called Patient Site. And you can fill this slide, please. And this allows us to do secure messaging with our doctors. It allows patients to do frictionless things like get a renewal of a prescription or get an appointment or get referral information, view their bill online. It allows them to do education. They can search for information online. I can prescribe information instead of just prescribing medications. And there's plenty of other things. Next. But the really cool thing is that patients can see their records online. This is that type 2 information we talked about, right? So this is viewing records throughout our healthcare system, including upcoming appointments, medications, problems, allergies, and even notes now. So it's really a very important tool for patients to get more engaged in their health and something that we could spend a whole session talking about. But viewing notes is particularly interesting and is relatively new, but I think now most people have access to their notes. Next. When I asked patients to comment on this portal years ago, I had one patient who was a 58-year-old male consultant who had high blood pressure. He said, "This is too cool. It's almost silly that things can be this easy. I am having a very good patient/customer experience so far." So that's an example of somebody who had a huge benefit from this because he realized that he's a customer. And in his 50 odd years of being on this earth, he had never been treated as a customer. He knows he's a patient too, but he's a customer and he's not treated like a customer. And he thought this was a huge step in the right direction. So the convenience was important. Next. Other patients get other benefits. This is a 61-year-old minister who was crippled with diabetes and severe chronic pain. He used a walker, couldn't get out of his house much. For him, this was the impact. I have a lot of medical issues. This system has left me feeling comfortable and in good hands. Otherwise, I always feel as cold, depleted, and alone as the lifeless tree in my front yard in the deepest of winter. We're in Boston, by the way. Winters are tough. So this was a lifeline for him. So different patients get different kind of benefits from it, but I would say everybody can get some benefit out of this. Next slide. So the next thing I want to bring up is that health happens between visits. So what you're looking at here looks like a light blue square with a little inset there. And what you're actually looking at is you're looking at a graphic that was developed by a graphic designer named Sarah Rigara, who is in Sweden. And Sarah put this together. Sarah has Parkinson's disease. And what she realized is that doctors think they know what's going on with her, and they think they can keep her healthy. But the reality is, and this is where you get to the inset here, to manage her Parkinson's disease, Sarah spends 1 hour in neurologic health care and 8,765 hours in self-care per year. So each one of those little blue dots that's making up the big square is an hour in her life, and there's one little tiny red dot. And the fact is, when I look at my patient population, even the very sickest patients I have, the patients who are hospitalized frequently, who are always seeing specialists or me, even they are only seeing healthcare, the healthcare system, for a tiny fraction of their lives. The rest of the time, they're on their own. They're taking care of themselves. Another way to think about this health happens between visits is something that my friend and dear colleague of many years, Patty Brennan, who just parenthetically, Patty's amazing. She's a professor of nursing and engineering and is the first woman and first nurse who is the head of the National Library of Medicine at the NIH. But Patty's very interested in consumer health. And she said, she years ago called this the care between the care, which I really love, and I've stolen that. Next slide. So in healthcare, I'm just going to give you my view of the world as a doctor who's been acculturated in the healthcare system. The way we learn about healthcare is this. We learn about professional care. We learn that there's such a thing as primary care, and there's secondary care, and there's tertiary care. And by the way, those are expensive, but that's what we talk about. Next. Tom Ferguson pointed out, he's the same Tom Ferguson who created the word e-patient. He pointed out that there's a whole world of healthcare out there that's self-care. It's this care between the care. It's stuff where patients are generally taking care of themselves. Next. And we discourage that in healthcare. You know, we poo-poo it. We say, oh, you're doing things on your own at home. No, that's not okay. You're seeking out health information. No, that's not okay either. All we really care about is the primary, secondary, and tertiary care. It's kind of like, if those of you who are old enough to remember, there was a New Yorker cover many years ago. I think it was in the 80s or maybe the 70s, which was a New Yorker's view of the world. We are myopic. We only understand what we see. We don't think outside of that. So we're discouraging cost-effective self-care, which is off the map, and encouraging the expensive healthcare. And recognize the fact that we're at almost 20% of our economy is spent on healthcare right now. This cannot stand. Next. Tom called this industrial age medicine. Industrial age medicine. Next. Tom suggested that we turn this on its head. We should encourage individual self-care, friends and families, and self-help networks. And then eventually, sometimes get to professionals as facilitators, professionals as partners, and sometimes professionals as authorities. Next. So we should be encouraging these things, discouraging the expensive things. Next. And Tom called this in information age health care. Next. If we had time, we actually do have time. I guess without the live audience, I'm speaking a little bit faster than I usually speak. I guess we'll leave more time for discussion this way. Maybe that's okay. But there's a lot to talk about, not just about the self-care side, but about how we can be partners in health as you take care of yourself outside. What are the tools and technologies and teachings that we can offer so that we can help take care of you even when you're not in the office? So the collaboration, this collaboration that I talked about, participatory medicine, leads to benefits. You can click through this slide. It leads to reduced costs, improved satisfaction, and better outcomes. And that, in fact, is the triple aim. And in fact, next, it's not just improved satisfaction for patients, but it's actually improved satisfaction for healthcare professionals as well. Because when practicing wisely and well and embracing all of this, it should not be stressful. It should actually help with your job satisfaction as a health professional. So I think that's really, really important. It shouldn't be burdensome. It should benefit everybody. Next. So let's talk for a few minutes about respect. Let's talk about meeting patients where they are, which is critically important. So we can't foist all of this upon everybody. You have clients, you have patients you're working with who are not ready for this. So that's an issue when people are not ready for participatory healthcare. And I see patients like that all the time. I take care of a huge diversity of patients, some very sick. They have all different socioeconomic backgrounds and everything. So in that case, what I do is I follow a behavior change model that was developed by James Prochaska and colleagues. And it's become known as the Prochaska model, the Prochaska trends theoretical model. And the idea there is you assess someone's readiness to change. And it doesn't matter whether this change is stopping smoking or cutting down on drinking or starting exercising or being an e-patient. So what we do is we evaluate everybody and we sort of figure out which box they're in on the readiness to change spectrum. They may be pre-contemplative, which means that there's no way they're ever going to do this. They don't want to do this. They don't care. The next model is, okay, they're contemplative. They're thinking, yeah, maybe I should be more engaged. Maybe I should register for that portal, for example. Those kind of things. That's contemplative. And then the next stage is where you're preparing. You're actually preparing to make a change. And then you're taking action. You're making the change. And then finally, there's maintenance. There's maintaining the change that you made. So I try to guide my patients through this. I want them all to become e-patients because it's much more satisfying, as I mentioned. Next, how about that you don't have the technology or skills? No, sorry. I didn't mean to make you do next slide. Sorry, backwards. Okay, the next on this is that some patients don't have the technology or the skills or the education. Well, here's where education comes in. Discount coupons, loaners of technology, alternatives. We can't, for example, shut down our phone systems because we put up a patient portal. We can't get rid of our phone staff. Phones are going to continue to be important. So there are ways to deal with that issue. The next is general literacy. In general literacy, we've got to identify the issue because, as we know, we often don't identify when patients are struggling with reading. We can use graphical and video resources for them, which can be useful instead of printed or written resources. Numeracy, I'm sorry, I skipped one. Limited English proficiency, that's another thing. We need to make sure that we have multilingual websites or materials. We need to make sure we have interpreter services. And by the way, if your patients aren't able to communicate with you in English on the portal, or a language that the doctor understands, we need to make sure that an interpreter or a family member can help them. Numeracy, again, the answer is simplifying resources and education. Health literacy, education, simpler resources, same thing. Cultural issues. Now, these are very important, and you may deal with those in your clients as well. So we need to appreciate that everybody has diverse attitudes towards healthcare and engagement. There are people who have huge distrust of the healthcare system that goes back many generations. A lot of African Americans, for example, really have this innate distrust of the healthcare system. And that is based in history, because we've done terrible things to African Americans in this country in the area of healthcare. But there are other cultural issues as well. For example, in traditional Asian populations, probably not so much South Asian as East Asian, you don't tell people that they have cancer. Families are very uncomfortable with this. And so we've got to understand these things and bridge those gaps. And then there are financial issues we need to deal with. We need to provide financial assistance. We should have a community resource specialist who can help our patients. We have to have transparency. And we need to discuss with patients, and I'm saying we as doctors need to discuss with our patients when we're ordering things. I was just discussing this with one of the attending physicians in we have an academic practice, so we teach residents. And one of the residents was upset because she was a new resident, so she's an intern, just started out, and she was ordering a whole bunch of baseline blood tests on her patient. And I told her, I said, why are you ordering those? There's no evidence that we need to be ordering these tests. And by the way, your patient is probably going to get billed for that. I know that my daughters, who were in their 20s, when they first started having their own health insurance, they had sticker shock. They said, the doctor said she was going to order a few tests and it's costing me $250. What's up with that? What's wrong with this system? So I think we need to appreciate the financial issues that our patients deal with as well. And then the distrust of the system. We talked about some of the cultural issues, but we also need to have a diverse staff. We need to identify and address any patient concerns that exist. Next. One of my dear departed friends and mentors was Professor Warner V. Slack. And Warner Slack, a professor at Harvard Medical School, wrote, "The largest and least utilized healthcare resource is the patient." The largest and least utilized healthcare resource is the patient. Next. Warner wrote this not recently. Oops, we have a formatting issue. He wrote this go back. He wrote this in 1976. He wrote this in the 70s, for God's sake. And yet nobody really listened. Because I would argue that we have marginally a patient-centered healthcare system today, and we don't appreciate the fact that the patient is an underutilized resource in healthcare. And he wrote this in 1976. Next. I'm going to spend a couple minutes talking to you about the Society for Participatory Medicine. Next. So this is a nonprofit organization that you can visit, and I'd love you to join. It's participatorymedicine.org. I happen to know that we have some of our members in this conference because we have a lot of members who are health advocates, who are caregivers, who are patients, who are also healthcare professionals, educators, researchers, and so on. Participatory medicine is a movement in which patients and healthcare professionals actively collaborate and encourage one another as full partners in health. That's participatory medicine. It's this collaboration that we were talking about, but there's a mutualism to it. Collaboration is two-sided. So I want to see doctors encouraging their patients, healthcare professionals encouraging their patients to be more participatory. But I want to see patients pushing their healthcare professionals as well. Next. We focus in several areas: building community among, with diverse viewpoints, doing advocacy, not the kind of advocacy you do, but this is influencing public policy. Oh, there we go. And we also publish research in our peer-reviewed journal, the Journal of Participatory Medicine. And by the way, that includes patient and caregiver stories, the narratives. And finally, we focus on education. And we do that through live conferences and webinars and through resources that we're increasingly adding to our website. Next. So join us. Next. Okay, there we go. So this is something that was really cool. And this came out of work at one of our conferences. In late 2019, we had a whole bunch of diverse people in the room, about 200 people, I think, in the room. And we did an exercise to try to understand what are core principles of participatory medicine that we should be all practicing, and trying to figure out how this gets manifested if you're a healthcare professional or you're a patient caregiver, a patient or caregiver. There are other people who are involved too, but we wanted to focus on them because I think they're central to the society. And so we developed this manifesto. And the principles are, so it goes like this. I pledge my commitment to the Participatory Manifesto and promise to do the following: share and listen, respect one another, share information responsibly, promote curiosity, and be a team builder. And why is it called a manifesto? You say, oh, manifesto, that's like the Communist Manifesto, or it's like Theodore Krasinski. You know what? Why? Because I'm fed up, and you should be fed up, and our patients should be fed up. We need to make things different. Vic Montoro developed a group called, he wrote a book about this, and that's why I'm hesitating to call it a group. It's really a book and a movement, and he called it Patient Revolution, because that's what we need. We're using terms like revolution and manifesto because the system is seriously broken, and incrementally changing it is darn hard, and I don't know if it's possible. So yeah, maybe manifesto is a little bit strong, but this is critical. Next slide. So through this exercise that we did online, and we got a lot of feedback on it, we developed I will statements. And the I will statements are for patients and caregivers and for healthcare professionals. And you can go to signthemanifesto.org, which I think is on there somewhere, whatever, signthemanifesto.org or the Participatory Medicine website, and you can see this and you can sign your name to say you support these principles. Next. All right, so here's the story. We have a changing nature of the relationship between patients and healthcare professionals. This is a real picture of a patient of mine and I, and he's allowed this picture to be used. In fact, some of you may know this guy. This is e-patient Dave. We are two of the founders of the Society for Participatory Medicine, and we talk about our story of participation publicly. And Dave has written extensively about it. Next. We're moving from information asymmetry to information symmetry. Next. We're moving from patients being passive recipients of information to being active partners in their care. Next. We're moving from paternalism to participation. Next. And because of all this, we're moving from not just a patient-physician relationship, but this is also a consumer-provider relationship. I don't like those terms, consumer-provider, but the point is there's a customer in here too, and that's part of what's going on. Next. So what I teach doctors and nurses and other health professionals is I want you, when you're looking across your desk at the patient and caregiver who are there, I want you to imagine yourself or your family member there. And as I said in the beginning, what kind of care would you want to have? What kind of treatment, not just care, but caring, would you like to have? Next. Next. So we have an aging population, an increasing burden of chronic disease, and it is straining our resources, our financial resources, our healthcare systems. Next. We need to demand more of our healthcare system while appreciating and understanding its limitations. That means that patients and caregivers, and we need to understand the limitations of the healthcare system. That's really important because they don't always understand it. We can't change everything overnight. As a doctor, if I'm your doctor, I only have a limited number of hours per day. You need to understand how reimbursement works, all these kind of things. But I'm optimistic. Viewing healthcare as a collaboration can open our minds to healthcare transformation with the patient at the center. And it's essential to improving trust, outcomes, and satisfaction. Next. So I have additional materials and resources at this link that you can see there. Soon we will have them on a formal webpage at the Society. On your lower left, you're looking at Let Patients Help, which is a book that ePatient Dave and I wrote. I should say I wrote part of it. He wrote most of it. But it's a really nice handbook that I think you and your jobs would find very useful. And then in the lower right, you're seeing the link to the Society for Participatory Medicine, as well as my contact information, because I would certainly love to hear from you. Thank you very much. And I think we can open up for questions, and I can get my picture back on the screen.
Sounds great. That was wonderful. And for people who were looking at the resources, we will get you an updated copy of the presentation for Dr. Sands following this presentation. So that will be updated. So Dr. Sands, we have a lot of questions active in the chat, so we're not going to get to everybody, but we'll get to some of the questions. So you may want to poke in there if you have a few extra minutes afterwards. But
for some reason, yes, when I'm looking in here, I don't see the chat. I don't know why that is, but
yeah,
but I'm going to let you read them to me.
I'll read them to you if that's okay. So this is from Sarita Nolan. What is your recommendation to patients who feel like their physician is resistant to active collaboration? And for instance, she speaks specifically for the disability community when doctors, maybe people don't want to tell too much of their story, and they feel that doctors might see that resistance as disbelief or denial of care or something like that.
I think that it is very important that you have a collaborative relationship with your healthcare professional. So yes, that's important. If you're not having that from a doctor, you should call them on it. You should say, look, I don't think this is really working out. I keep trying to engage in my healthcare and have a collaboration with you, but I feel like you're making it difficult for me. Can we talk about that? And have a discussion about it, because it may be that you're just not a good fit for one another. Or it may be that doctor needs to learn more about participatory medicine. But it's like finding a girlfriend, a spouse or a partner or whatever. It's not always a perfect fit. And I know in some parts of the country, it's hard to find a doctor, but I think it's important.
Yeah, and that was actually one of the questions is, I think that your concepts are amazing, and we wish that every doctor were like you. So it's hard to find doctors that actually have that participatory mindset. So is there something through Society for Participatory Medicine that's like a stamp of approval or something like that in terms of providers who've signed the manifesto or are familiar with it?
Yeah, thank you for that question. So no, we haven't made that available yet. What we are talking about, we started and then we didn't follow through with it, was having doctors and other healthcare professionals sign basically a manifesto, sign off on these principles and say, yeah, I commit to practicing this way. So it really is basically signing the manifesto, but then making that available in a database so that you can look up doctors and find a doctor who signed off on this. We did not have enough resources behind it when we tried this many years ago. I think that we'd like to reattempt that because I think it would be a very important service. So yes, stay tuned. Yes, hopefully we can do that.
Sounds like a good idea. Okay, let me go to Leah Christo from Assumption University, who has this question, which is, what recommendations do you have to help our collaborative advocacy organizations get more recognition of our value, meaning independent advocates, to the healthcare industry leaders?
Well, that's a great question, Leah. And I'd say that you're absolutely right, that health advocacy is not something that we're taught about in medical school. It's not something that, it's just not something that's normally taught. And I think we need to be educating people about this. And I think that maybe step one is you do this one doctor at a time. as you go in for your encounters. I'm a health advocate, and I'm working with Mary Jane because, and this, do you know what a health advocate does? Let me just tell you, and spend, a minute doing an elevator pitch about health advocacy. But I think that what I'd like to see is I'd like to see more time spent in medical school, a little bit of time understanding what this is, teaching about what this is. And I think there's an opportunity to get health advocates to speak at medical conferences, continuing medical education conferences. But it's hard because healthcare is really hard to penetrate. It's hard to get doctors to change the way they practice, change the way they think. Studies have shown that it takes 17 years for a proven best practice to permeate doctors' practices. So it is an uphill battle, but I do think it's important.
Yeah, we heard from Doctors Dunham and Camo in the previous session that there's so much pressure in the healthcare system right now because there's lack of staff and lack of resources. So it's tough time.
And that's why, by the way, that's what I was
Yeah,
saying. Or the other thing that related to that is it's just so important that, it's not like we have to say, oh, poor doctors. I'm not asking for pity, but I'm asking for understanding. We just need to understand each other's perspective, just like I need to understand your perspective, your patient, your point of view, your background, and whatever. You need to understand where I'm coming from as well, and the limitations of our system. Next, sorry.
It's the compassion. So one of the presentations that we offer to be licensed to health advocates to give to the public is the ABCs of an effective doctor visit. And the C in that ABCs is compassion. And that's exactly what you're talking about. So let me go ahead and take this question for you from Diane Savastano, who's actually in your neck of the woods. She says, I'm a huge fan of open notes and have used the tool with clients and personally for years. They're incredibly empowering. Please comment on the resistance to this and how BIDMC overcame resistance among physicians. Comment on behavioral health open notes. That's from Diane. Thanks, Diane.
Wow, Diane, that's loaded. We could talk about this a long time. I think that, let's just bring it back a level. When we went live with Patient Site, our patient portal, it was the year 2000, so it was 21 years ago. Can that be? Wow. Yeah, we're in 2020. We're 21 years ago. We went live with our patient portal, and we let all of a sudden patients see their medical records online. Everything except for notes and a few other selected things. And that was the huge cultural shift. And one of the things that happened is that we just did it. We thought it was much better to beg forgiveness than to ask permission. So we just went ahead and did it. And yeah, we stepped on some toes and some people were upset about it. Specialists were saying, what do you mean you saw your CT scan results online? So that was a huge cultural shift. And over time, we altered the system. So we embargoed certain test results for a finite period of time to make sure that patients wouldn't be too alarmed, to give their healthcare professionals a chance to review the test first. But the point is, we just did it. When we look at the other major health system here, which is the Brigham Partners Healthcare, they went live with the patient portal after ours. And they did it through committees. They said, well, let's get a committee together and discuss this and so on. They went through a very thoughtful and deliberative process, and it took them much longer to go live. Maybe it was an easier transition, but I say rip the Band-Aid off. So we started with open notes as a research project, and people could sort of opt into that. And then when the studies came out showing that it was accepted by the vast majority of doctors, then we were able to convince the administration that, it's fine. Nobody's going to get hurt. It's all going to be just fine. So I think that that's really part of it. It's about educating physicians that it's, the world's not going to end. It's all good. Just like with looking at test results. It's really good. Good things are going to happen here. But there is certainly an educational process about how we write our notes. And so the Open Notes team, which of course still exists, is trying to do all this education about how we can use open notes in our practices, how it's not a scary thing. This is the education and research and so on. Now, mental health is a whole other interesting thing. We did a mental health project with open notes where we let patients see their mental health notes online. But we did allow the healthcare professional who's taking care of the patient, the mental health professional in this case, to not share certain notes, because I think sometimes it's probably okay to do that. And in fact, anybody, not just mental health professionals, can keep a note from being shared. And there may be good reasons to do that, but I think it's not a frequent thing, and we shouldn't be doing it a lot. And I think it can be very helpful for many people. I think it may not be helpful with a certain class of patients who have certain mental illnesses. So I know that's a long answer, but not nearly long enough. We can talk later. Thank you.
Okay, and Danny's contact information is in his slides,
Yes.
and very responsive. It's been wonderful to work with. We have one last question from Gabriel Huckberg, who says, "How do we work with doctors who work in the hospital? No patient feels today that there's anyone who takes care of the care, given that hospitals hire hospitalists." This is a serious issue.
This is a serious issue. Yeah, it is a very serious issue, Gabriel. It's healthcare is sufficiently complex that we have taken doctors who practice in the outpatient setting, like me. I'm a primary care doc. We're just so busy taking care of our outpatients, and reimbursements are so suppressed that in order to make ends meet, I've just got to see as many patients as I can. And taking time away to go see a patient in the hospital, particularly when hospital care is just changing in dramatic ways, and I'm not going to, that it just doesn't make sense financially for me. And frankly, it doesn't make sense for the patients either, because people who spend their lives in the hospital, taking care of patients in the hospital, have been shown to do a much better job. Now, you are absolutely right, though, that when you move to the hospital setting, people are coming and going in shifts. And sometimes communication gets screwed up in the hospital. One person tells you something, somebody else comes in and tells you something else. I don't know how we're ever going to get rid of that whole problem. But I do know that people are doing studies about letting patients see their their notes, for example, when they're hospitalized. And that may be part of the solution. But I can tell you, when I drop in and pay a social visit on my patients who are in the hospital, sometimes it's a little confusing to me, even when I'm looking at the notes and reading the records. But I think that part of it may be that we need to educate patients more about who's in charge. So if you're in a regular medicine service, for example, you need to understand that it's the hospitalist who's in charge. That's the head of the team. All those other specialists may have a perspective and a point of view, and they're all coming and going. They may tell you things, but the master of the plan is not the specialist. On the other hand, if you're on a specialty service, you're on a cardiology service, then the cardiologist is running the show. It's messy and it's complicated, and people don't stay in the hospital really long enough because the reimbursements are, again, so low that I don't have any great answers there, except that I think that transparency is going to help, and also patients and caregivers understanding, who's in charge is another piece of this.
Yeah, absolutely. And that's the last word for the last full session of today. Dr. Sands, thank you so much for joining us and for that information. It was really fantastic. And there are a lot of other questions, so I hope you might be able to peek at them before
you
you go.
If you can figure out a way to send
evening.
them to me, and I'll try to find a way to help. And it's just such a pleasure to be able to speak to such a group that's doing such great things. Thanks.
Thank you so much. We'll take a short 15-minute break, and then we'll come back with the Let's Chat networking event. And as you might remember, that's going to be on Zoom. So you have to pre-register and receive your unique link that you will use to enter the Let's Chat happy hour. Okay, see you in 15.